What is the most common indication for initiating hemofiltration, CRRT, in a patient currently on ECMO support? A. Isolated hyperkalemia, K plus greater than 6.0 millimoles per liter. B. Fluid overload unresponsive to diuretics. C. Prophylactic prevention of AKI. D. Drug overdose clearance. Answer: B. Fluid overload unresponsive to diuretics. Explanation: fluid overload is the primary driver for CRRT in ECMO patients. While electrolyte imbalances are indications, the inability to manage fluid balance with diuretics in a capillary leak state is the most frequent reason for initiation. In a patient on VA-ECMO, which of the following metabolic derangements is a hard indication for starting hemofiltration? A. Mild metabolic alkalosis. B. Serum creatinine of 1.5 mg per deciliter. C. Refractory metabolic acidosis with pH less than 7.2. D. Urine output of 0.5 milliliters per kilogram per hour. Answer: C. Refractory metabolic acidosis with pH less than 7.2. Explanation: severe, refractory metabolic acidosis, often lactic acidosis in ECMO patients, that cannot be managed by adjusting sweep gas or flow is a clear indication for hemofiltration to correct the acid-base balance. When integrating a CRRT machine into an ECMO circuit, where is the most common access point for the CRRT intake? A. Before the ECMO pump, negative pressure side. B. After the oxygenator, positive pressure side. C. Directly into the patient's internal jugular vein. D. Between the pump and the oxygenator. Answer: D. Between the pump and the oxygenator. Explanation: connecting the CRRT pole after the pump but before the oxygenator, or using the manifolds provided on the circuit, is standard. This utilizes the pressure generated by the ECMO pump to drive flow, though it requires careful monitoring of pressures. What is a primary non-renal indication for using high-volume hemofiltration in a patient with septic shock on ECMO? A. Removal of inflammatory cytokines. B. Increasing the hemoglobin concentration. C. Cooling a hyperthermic patient. D. Improving oxygenator efficiency. Answer: A. Removal of inflammatory cytokines. Explanation: although controversial, high-volume hemofiltration is sometimes used in severe sepsis to attempt to filter out pro-inflammatory mediators, cytokines, that contribute to vasoplegic shock. Which electrolyte abnormality, common in massive blood transfusions during ECMO cannulation, is an indication for emergent hemofiltration? A. Hypomagnesemia. B. Refractory hyperkalemia. C. Hypercalcemia. D. Hyponatremia. Answer: B. Refractory hyperkalemia. Explanation: massive cell lysis and transfusion of aged PRBCs can lead to life-threatening hyperkalemia, which hemofiltration can correct much faster than medical management in the setting of renal failure. A patient on VV-ECMO for ARDS has a cumulative fluid balance of plus 15 liters. What is the benefit of starting hemofiltration here? A. To increase the PEEP on the ventilator. B. To reduce pulmonary edema and improve lung compliance. C. To decrease the risk of circuit thrombosis. D. To increase the cardiac output. Answer: B. To reduce pulmonary edema and improve lung compliance. Explanation: reducing total body water, deresuscitation, via ultrafiltration helps clear pulmonary interstitial edema, which is crucial for resting the lungs and eventually weaning the patient from VV-ECMO. Why might hemofiltration be indicated in a pediatric ECMO patient with high levels of free hemoglobin? A. To prevent hemoglobin-induced acute tubular necrosis, ATN. B. To increase the life of the oxygenator. C. To treat thrombocytopenia. D. To reduce the sweep gas requirement. Answer: A. To prevent hemoglobin-induced acute tubular necrosis, ATN. Explanation: hemolysis is a risk on ECMO. High levels of free hemoglobin are nephrotoxic. Hemofiltration can help clear these pigments and manage the resulting kidney injury. Which of the following is an indication for hemofiltration related to standard of care in multi-organ dysfunction syndrome, MODS, on ECMO? A. Serum urea greater than 100 mg per deciliter, uremia. B. Alanine aminotransferase, ALT, greater than 40 U/L. C. Patient is unable to tolerate enteral feeds. D. Heart rate greater than 120 bpm. Answer: A. Serum urea greater than 100 mg per deciliter, uremia. Explanation: symptomatic uremia, pericarditis, encephalopathy, or high urea levels, typically greater than 100 mg per deciliter, remain classic indications for renal replacement therapy, regardless of whether the patient is on ECMO. In the context of ECMO-RRT integration, what is the risk of using the CRRT for fluid removal? A. It increases the risk of air embolism if not monitored. B. It always causes the ECMO pump to stop. C. It makes the blood too thick to oxygenate. D. It prevents the use of heparin. Answer: A. It increases the risk of air embolism if not monitored. Explanation: anytime a secondary circuit is spliced into the ECMO loop, there is an increased risk of air entry or disconnection. This is an indication-related risk that requires strict nursing protocols. Early versus late initiation of hemofiltration on ECMO is debated. What is generally considered a trigger for early initiation? A. When the patient stops making urine entirely. B. At the first sign of a positive fluid balance that cannot be reversed by 20 mg of Lasix. C. To facilitate aggressive nutritional support without fluid overload. D. Only when the pH drops below 7.0. Answer: C. To facilitate aggressive nutritional support without fluid overload. Explanation: one major indication for starting CRRT early on ECMO is to make space for necessary intravenous medications, TPN, and blood products without worsening the patient's fluid status.